make a biopsy, and we have first an conservative treatment. We will make a neoadjuvant chemotherapy. Afterwards, we will make a wide resection and implantation of the megaprosthesis, because I will show you soon the background. Next, on the right side, we will make an immediate surgery, because the background is on the left side. We have a curative option, because it's a Ewing sarcoma, with the option of the wide resection and tumor-free survival. On the right hand, this is a metastasis of a female patient, of course, with a multilocular metastasis of the bones and viscerals. So what is influencing the survival? This is about sarcomas. This is from Birmingham, and you have a survival nearly 80% after 2 years, and you have a survival 10 years of about 30%. In contrast, you see bone metastasis in a lot of patients with metastasis, not only breast cancer. They will have a survival of only 40% after 2 years, and a survival nearly now after 10 years. So this is influencing your treatment. Bone sarcomas have an option for curative therapy, multidisciplinary treatment. They will receive first neoadjuvant chemotherapy, then surgery, and completed by an adjuvant chemotherapy. In contrast, bone metastases are mostly treated in a palliative way, because we don't have any influence on the survival with surgery. I will show you this in the next slides. As you have heard from the first speaker, breast cancer is one of the most important primary causing bone metastasis and visceral metastasis. This is the overview from a very active Scandinavian group. And on the right hand, you will see the grade of osseous dissemination. So a lot of cell invasion you will have in most of the patients suffering from carcinomas. When you're looking for the survival rate just after 1 year, you will see that there's a survival rate of 50%. Only myeloma and lymphoma have a better life expectancy, and the most worst is in lung cancer patients. So the long-term survival is very different. This is a publication from the JCO from Marathon in 2005, and you can clearly see that lung cancer is a very bad cancer, and the most or the best is the renal cancer, and the breast cancer is in between. So what is the influence on survival in a lot of cancer patients, not only breast cancer, because there's only a few papers on this? There's a significant difference if there are visceral metastases or not. This is highly significant, and you have a better survival without visceral metastasis, just bony metastasis. On the other hand, this is the comparison between the detection of a solitary bone metastasis or multiple metastasis. This is the same author, and as well, here is a highly significant difference. And further on, the life performance, this means Karnofsky index, is also influencing the survival rate. So, and this is another very important thing. It's prognostic, because the development of a metastasis either metachronically or synchronically is also influencing the survival, of course. if you have a metachronic metastasis, this is a better survival than synchronic development of the metastasis. When you are looking regarding the surgical techniques, there is only a few papers dealing with different methods to treat this metastasis. There's a comparison from also the Scandinavian group and comparing osteosynthesis with endoprosthesis, and you can clearly see the complication rate or failure rate is very rare in endoprosthesis and it's high in osteosynthesis. And the most important reason for the failure is the long survival of the patient. On the other hand, you can see this is the same group as you see. The risk for reoperation in osteosynthesis is very high, and if you use an endoprosthesis, it's very low. And the revision-free survival is very similar, and you will see some more effects regarding the methods I will show you further on. Looking after the technique, either an extralesional resection or an intralesional resection, you will have a better outcome when you do an extralesional resection. This means removal of the tumor mass. But this is from Windhager from Vienna. The survival after an extralesional resection is worse than after interlesional resection. So you have to decide for every patient what is the best for him. Otherwise, the local recurrence is less when you remove these masses. So there are some unknown facts influencing the total results. And the bone healing rate is in myeloma 66%, and in contrast, lung cancer has no healing in the bone. This is broken by a pathologic fracture. So this is the same as another analysis from 2013. There's no difference in the techniques, but I think I will show you the slides regarding the technique, and you can decide by yourself. So pathological fractures are significantly influencing the survival, as you see here, and most of the patients are suffering from metastasis in the femur, in the pelvis, and the vertebral column, but these patients with metastasis in smaller bones have a better prognosis. Once again, Karnofsky index is highly influencing the survival. There's no influence by the operating method, and also the low hemoglobin content is a life-threatening factor. So this is once again the 1-year survival. Solitary metastasis, mostly half of the patients are surviving after 1 year, and visceral metastasis, as my wife will show you in the next speech, are significantly worsening the results. So there's only 2 or 3 minor major papers regarding breast cancer, and there's a paper from Mendoza and also this year published some significantly influencing factors. This is the stage, tumor size, lymph node involvement, lymphovascular invasion, estrogen receptor positive, progesterone receptor positive, and the triple negative status. On the other hand, regarding the visceral metastasis, there are some factors also, 8 factors, which are connected with a highly significant influence, as is shown here. So, long-term survival, of course, is depending on the stage of the breast cancer. This is published by Hagberg and et al., also published in this year. And once again, another group from South Asia is reporting the influence on the survival. No metastatic lymph nodes, estrogen, recurrence-free interval, no bone metastasis, endocrine therapy, and as well as we know since a few years, bisphosphonate therapy is very influencing the survival with a way which we don't even know, really. So, surgery is not influencing the survival, and if you are looking regarding the indication for surgery, just in cases with pain as an indicator, this is the same result, reducing the pain after radiotherapy compared with surgery. So, treating bone metastasis is a multidisciplinary option or aim, and the surgeon is only one of the whole group as shown here. So we have to decide when do we make the surgery, which metastasis should be operated on. This is really very clear to us. Impending fractures, of course, pathologic fractures, painful metastasis, otherwise not treatable, solitary metastasis, then we have to decide whether we are doing wide or intralesional resection, and of course, spinal metastasis with rapid progress to neurological impairment. The same question, when should we operate? As I have shown you impending fracture, of course, pathological fractures, and you have to regard this is very immediate surgery only indicated when the diagnosis is clear. When you don't have the diagnosis of this lesion, you shouldn't do immediate surgery because it's very easy to make the diagnosis with a biopsy here taken from here and to detect the stage of the lesion or the stage of the tumor, meaning metastasis, is it a primary or is it metastasis? So now I will show you some cases. This is once again the question, how should surgery be done? As I have shown you, we have to decide it individually, and long-term survival is the most important risk factor for failure of the surgical method. So you do have to do it safe, simple, and short. And the last question regarding this, who and where should we do this surgery? We should do it in an institution with a high surgical experience because the complication rate and the success rate are better. So, how we do this? I like this compound osteosynthesis. This is a case of a renal cancer. We make an embolization. We implant this bone cement and make a plate. In another case, it is a very young patient, also with a renal cancer. We did the same compound osteosynthesis. This is a case of a female patient with a breast cancer. You have seen already this slide we made. We have seen this after a nailing procedure which doesn't function for a very long time. So we had to decide to remove all this because the nail was broken, as you can see here. And we implanted a proximal femur endoprothesis. So this is a mega prosthesis also used in sarcoma patients. The same here. This is a metastasis of the renal cancer, leaving the tumor behind, and it happens like it was feared. The nail broke, and we implanted a very long proximal femur replacement. On the other hand, this is a patient where with an adenocarcinoma of the lung, the primary surgeon didn't remove the metastasis, and we had a loosening, and we had no really cementing, very good cementing, so we have decided to implant an proximal femur replacement. But this is not without any complications. This is a young patient with a renal cancer. This stem has broken, and we had to remove and to resect the whole thing and implant a new prosthesis. Once again, breast cancer of the humerus. This is a compound osteosynthesis with a loosening, breakage of the plate, so we decided to implant an proximal humerus replacement. Lung cancer, once again, this is a little bit over-treatment because we know lung cancer patients are surviving very short. And this renal cancer patient, very multilocular renal cancer with a very distant metastasis, and we made an arthrodesis. So you can see the surgical options are very different and are used very individually. Once again, pelvis tumor, this is a prostate cancer, solitary metastasis. In this case, solitary metastasis with a very simple removal procedure. We decided to make a wide resection because of the state of the disease, solitary metastasis. This is the postoperative view. And once again, renal cell cancer with a larger tumor in the pelvis like this. It's very difficult to treat with a right resection, so we decided to make a palliative resection, implanting bone cement with a pelvic partial replacement and the normal endoprosthesis. What's the innovation for vertebral column procedures? We have now in breast cancer, for instance, minimally invasive approach regarding the sentence says simple short. This is the situation, operation time 90 minutes. And this is the last picture, or one of the last pictures. I will show you my star patient. She has been suffering from a thyroid cancer in 1994. He has received a palliative procedure then she came again, had a new metastasis, so we decided to make a wide resection, removal of the whole tumor within wide margins. She received this partial pelvic replacement, but unfortunately 10 years after, we have a breakage of the prosthesis, so we decided to make a new one, and she's visiting my office every year again. This is her gait, of course, a little bit disturbed, but she's bicycling every year 4,000 kilometers. Not a Tour de France or a Tour of Britain, but she is very well mood. So, summarizing bone metastasis, can you stop it? So, it doesn't work anymore. So, summarizing treatment, surgical treatment of bone metastasis is it's an individual decision because every cancer is different from the other one. If you have the option to have a wide resection within a good time, expected operation time, I will decide for a wide resection. Otherwise, you should remind that the most important factor is long life expectancy is a great fear of the surgeon because this disturbs his method and leads to a failure of the osteosynthesis or of the megaprosthesis. Thanks for your attention.
Medical oncologists know that in prostate cancer there are multiple in the small bones and so on. Because we had such a case, and other doctors criticized me because during weekend I received a call. I am professor, and so, and it was the chief himself, well-known rheumatologist. And his collaborators wanted to dictate me a lot of tests, and I said, so because he said, I have some pain, but he had a sportive life, going in mountains. And I asked for PSA. They didn't perform. In Bucharest University Clinic, because nobody thinks. Man, we are obliged after 6 years to make PSA. And we urgently made, PSA was very high, and I answered, Professor, you will not need to go to urologist, we have medical treatments. Your diagnosis is prostate cancer with both meds. Doctor, you even didn't consult me, but we have protocol. Shortly, he went to the orthopedic. Luckily, he had only this one solitary. Now he has 7 years of hormonal...
Excuse me, please ask the question.
Yes. The question is, why do you think this prostate cancer? Because it's not at all usual. Probably we have to look better in the genetic of this kind of meth. Only one, in my oncological life, it's the first case I saw, only one meth. Because every oncologist will think, bone mets from prostate, it's only medical treatment, radiotherapy. Why surgery if he possibly has multiple other bone mets? So we have to look inside, because you showed it's a personal evolution. We have to treat personally as technique. But for me, is why is this situation? So I will ask more about genetic background of this kind of meds. Are there clinical trials looking at this?
As you have heard in the first speech, this is sometimes an occult disease, and we have to decide whether we can make this simple resection like this in the pelvis part P1 without any major complications, just resection. I wouldn't implant a megaprosthesis in the pelvis when there is an occult metastasis within a patient with a high rate of PSA. So I unfortunately can't answer your question regarding the genetics, but I think there's no idea to put the genetics in the surgery, because surgery is a macroscopic procedure, and genetics is influencing the chemotherapy. So this is a very rare indication. Most of the patients with a prostate cancer have multiple metastases influencing or distributed all over the bony pelvis. So this is a very rare case. So I just wanted to show that the decision to do surgery is very individually and should be seen very critical.
Thank you very much.
Thank you very much for your answer. Next question.
In this kind of surgery, my question would be if regarding how long take the recovery after such a surgery, and if the patients have time to take advantage in their life from this complex surgery.
So recovery is depending on the extent of the surgery, of course. And if there's a patient with a lung cancer, we will do everything to bring him home or her home as soon as possible, because as you have seen, life expectancy is very low, and most of the patients are dead after 1.5 years. So on the other hand, as I have shown you, thyroid cancer, this is a very difficult surgery, and we made a second exchange of the replacement. This is only indicated, in my opinion, in thyroid cancer, or a very and cancer, which is very good treatable with chemotherapy or radiation therapy in an additional or adjuvant procedure. The recovery after megaprosthesis is depending on the soft tissue coverage, not on the bony reconstitution, because in these cases you will cement and they can walk around after a few days. So the hospital stay is 1.5 weeks up to 2.5 weeks, but you have to remember that megaprosthesis have a high rate of infection, and therefore we have a new improvement since years, because all the megaprostheses are covered with silver, because silver is known in sports, in every kind of the daily living, to reduce infection or to kill bacteria outside the human body. So this is a very good improvement, but it doesn't reduce the infection rate to 0. So we have an infection rate of about 4 to 5%. This is compared to other surgical procedures, the same rate. So the recovery rate or the recovery time is depending on the surgery, and of course is depending on the mood of the patient. If he wants it or he don't want. So when somebody is wanting it, you have a